Yes. Okay, let's see. I think we should be on in just a second.
The
yes,
Coastal Community Oncology
minute.
Lab at Western Washington.
Okay. All right. Well, hi, everybody. We're just figuring out all this technology, and we finally connected from Zoom to YouTube. So it looks like I think we have several people on with us now, and I am really excited to be here today. We have Dr. Elizabeth Peckham on with us. Welcome.
Thank you.
Yeah, I just would like to introduce Dr. Peckham today. She's been involved with a lot of our participants here in Austin and Round Rock. And she is a movement disorder specialist. So that means she specializes in the diagnosis and treatment of movement disorders such as Parkinson's. She has extensive experience with the evaluation for and programming of deep brain stimulators and Botox injections. She did her neurology training at Georgetown University in Washington, D.C., and her specialty training was at the NIH. She's been practicing as a movement disorder specialist, I believe, since 2007. Yeah. And she's been a longtime friend of Power for Parkinson's. She was recently included in the PBS documentary, Living with Parkinson's, along with 2 of our board members and several participants. She's an excellent clinician, and she continues to be involved in clinical research. So we're really happy to have you with us today and reaching our audience. I see on YouTube we have some locals on, and we have some people here I see from New York, and let's see who else we had in Canada. So we've got reaching several, reaching far and wide today. So so I thought maybe we could just start off our talk today just talking about like being a movement disorder specialist and what that means and what's the benefit for people with Parkinson's.
Sure. So a movement disorder neurologist, back a long time ago, there was actually not a fellowship for movement disorders. It's really one of the newer ones. But movement disorder specialists are physicians who've completed their neurology residency, and then they decide to go on and do a fellowship, which depending on where you go can be anywhere from 1 to 3 or 4 years. If you go to a program that's heavily involved in research, a lot of times it is a little longer program just because you see patients and you do some clinical trials as well. And I think that there are some benefits. I think oftentimes with that additional training, you obviously have more exposure to patients with movement disorders. The most common movement disorders seen are Parkinson's and then another form of tremor called essential tremor. There are some less well-known ones, like Tourette's or tics. Most people have heard of that. There are some other syndromes where patients have ataxia or walking disorders, as well as dystonias, and those are less common. But depending on where you train for your neurology residency, and at the time, mine was one of these, we really didn't have a lot of experience with movement disorders. We had a lot of headache and a lot of neuromuscular and different other fields, multiple sclerosis, but we didn't have movement disorders. Now Georgetown is a really big movement disorder program, but when I was there, it was just starting. So I think the benefit is if you can get additional clinical expertise, that's great. If you can't, if you're in an area where there's not a movement specialist available, then I think the other important thing is if you're seeing a general neurologist to ask them how many Parkinson's patients they have, and is that an interest of theirs? Because some doctors who were trained a longer time ago may have not had the opportunity to do a fellowship because it didn't exist. And other physicians who are general neurologists also just treat a lot of Parkinson's patients and really like it and probably have expertise.
Well, that is really great advice, because I know there's still It's still hard to find, and in some countries, it's hard to access a movement disorder specialist, and probably less, more rural areas is pretty tricky. I'm just curious, do you know, they talk about a lot of virtual access to, some in other areas. Is that something that you know anything about?
You mean as far as telemedicine?
Yeah, telemedicine.
Yeah, so I mean, I can just tell you kind of what we've done for our clinic. I mean, when COVID started, that first week, I would happen to be on spring break and my trip was canceled. So I kind of just set up telemedicine to start that next week and do the full week. I did telemedicine just only. And then after that, I started coming in the office 1 to 2 days a week initially up until the summer. And then I did the rest telemedicine. So I think I've had other neurologists say, oh, I would never do a new patient through telemedicine. But what I found is if I was going to wait to do new patients and see them in the office, I had several other regular follow-up patients that needed to come in, those that have a deep brain stimulator or clinical trial patients. And I didn't want to push people out further. So if they were willing to do it, I would at least start, get their history. I can't do an exam, obviously, but I would try to get everything I could, make a good dent in things, get an introduction, and then see them within, most patients I was able to see within a couple weeks in a follow-up slot, and then we go through the full exam there. So I think, if you're flexible in what you're doing, and as long as you can eventually complete the picture in a pretty, complete manner, it works. I've also had a handful of patients that I still have never met since March, and they are all 80 plus years old in a facility and either can't or don't want to be able to leave. And on the video, I was able to see their tremor was very classic for Parkinson's, and I started them on medication, and several are doing quite well. So, I want to meet them in the future, but, we have to balance things and, again, just try to adapt in this time.
Yeah, well, that sounds like that would be an important thing, and I know so many people have learned how to do that now, so maybe that is something that people in our audience, if they are having trouble, they might want to research that. So let's see, I know that we are getting some questions, but I have a couple before we delve into those. One of the things I thought would be a good thing to address, of course, since we have so many people exercising with us and getting involved. One of the things, could you just talk about like medication schedule and off times and how to maybe what the best way would be to take your medication so you're ready to exercise?
Sure. So I think, I think a lot of people do have to adjust their medication around their exercise schedule. I think that you want to, when you're exercising, make sure that you're really in a good on state and that you're not going to be transitioning and going off and then needing your medicine halfway through the exercise. So, for some patients, maybe that means taking their medicine a little bit earlier. I've also heard the comment from many patients that they may need a little bit more medication if they're going to do an intense exercise. So I've had some feedback from patients saying, well, the days that I do a more intense exercise, if I go to boxing, I need an extra tab, or, I take it a little bit earlier just to make sure that I'm getting through that. So, I think that's
And have you noticed that through exercise, have people, have you seen people have needed their medication less frequently?
Yeah, so what I would say is over time, again, it's kind of seeing the forest for the trees. Patients do much better. They do better in the short run, but in the long run, when you follow people, the patients I have in clinic who are doing the best are those that are exercising regularly and making that a priority. I mean, they tend to have less falls. They tend to be on stable doses of medication longer, even if they need more just to push through the exercise because they burn through it. Just as a whole, they're able to maintain their doses of medication for a longer period of time, need less medication, and just feel better. So.
Yeah, okay. That's what we see, but I'm curious how you deal with that in the clinic. Yeah.
And I agree. Because of that, that's the first thing I talk to. Anybody who's initially diagnosed, that's the focus before we even think about medication is exercise. Unless there's somebody that has to go on medicine, I really try to delay it, but really push the exercise.
So you would have them exercise first before starting
if they
how
have
they
a
feel.
mild tremor, or their symptoms are not bothersome or interfering with their activities of daily living, and they just need a diagnosis that they're able to do everything, yes, I put everybody who is willing to do it in physical therapy and strongly recommend exercise. And it's been more of a challenge with COVID because those things are more restricted. But.
Yep. So along those lines, I actually did get a question from one of our young onset Parkinson's participants who happens to be on our board. And he asked this question because he kind of considers himself pre-DBS. And he said, should he try to minimize his carbidopa, levodopa intake and tolerate the off periods in hopes of delaying the DBS?
Yeah, so it's a really good question, and I'd say that threshold is very different for every person. But I think in general, what the advice I give to people is we really want you on the right amount of medication that you can do everything that you want to do. I really don't want the quality of life, the activities that you're doing to suffer because you feel like you have to stave off taking less medication in the long run. I think it's really important to focus on that quality of life. And I've had other patients who take a little bit more medication and then they can exercise more and they can push through barriers that they weren't able to do on lower doses. And I think pushing through that barrier with a higher intensity of exercise is more important than trying to really keep your medication level. So.
Okay, that's great. I think that's great advice because I think people are still struggle with that issue a lot, and no one really, everybody wishes they didn't have to take any medication, but it's always that balance with Parkinson's. So let me see. I see some questions coming in here. Let me just look through here. Let's see. Okay, here's a question from Heidi, who's in upstate New York, and she would like to know about on-demand drugs that Parkies who are not on meds can take. And also, are there any vitamins or supplements you recommend?
Okay. So on-demand drugs, meaning something that you could take just for an off period or for tremors?
I think so, yeah.
Okay. So I'm clarifying. So you can do on-demand Centomед or any form of Centomed. I mean, any form of carbidopa, levodopa, I should say. So, which would include generic Centomed or Carcopa, which is an oral dissolvable form of carbidopa, levodopa. Rytari, you could also take on-demand. Probably, if I was going to do something on-demand, I'd look maybe towards Carcopa. It's just this oral dissolvable tab that you put either on top or under your tongue because it has a faster onset. Inbryssia is an inhaled levodopa. You cannot do that one on demand because you have to have carbidopa in your system. So that was really an adjunctive treatment. Where you have to have regular carbidopa in there to help convert the levodopa. There's a newer drug called Kenmobi that is sublingual under the tongue. Looks like a thin strip that you put under your tongue. Right now, truly the FDA indication is an add-on or adjunctive treatment to carbidopa, levodopa. But technically, could you do that? Yes, you could. But you're not going to get it approved by insurance unless you're carbidopa, levodopa. But it would be an on-demand potentially. For vitamins and supplements, this is something that I really wish I could recommend something. There are a lot of advertisements out there. There are websites dedicated to, touting certain ones. There are really no clinical trials that have proven any supplements that are better than placebo. There are several that have been looked at. They've looked at very high dose CoQ10. They've looked at vitamin E. Creatine has been looked at. And really none were better than placebo. I know there's Restore Gold out there, and only because it's advertised on Facebook and I get so many calls. It's kind of like Prevagen for memory. I didn't know it existed until I got so many calls. so there's really not anything that's definitive. A lot of the supplements that they base on are based on a molecular model of Parkinson's, and the problem is you could find 100 different things. And So what do you recommend? Do you say take 100 different supplements that may be effective? It's, you know, it's a hard decision, so generally I don't recommend.
Yeah, that's what I thought. Well, those are good ideas or good suggestions. Let's see. Okay. I see another question here about fatigue. I know I've heard you talk about it before, but fatigue is a problem for a lot of people. And this Grace, also in New York, would like to know, is it part of Parkinson's or is it related to medication?
That's a good question. Fatigue is such a tricky subject. So I try to go through an algorithm on fatigue on my own to figure out, you know, what could be causing it. So obviously, first things first, making sure you don't have some other cause of fatigue, and that would be making sure that your primary care checks your thyroid function, your B12, your iron levels, ferritin levels, which are iron stores, sometimes are decreased in restless leg syndrome. So that's something that, you know, potentially, even if your iron level is normal, but your iron stores are low, that could be something that causes fatigue. Vitamin D should be checked also. So doing that, other things about fatigue to make sure and get a good history on is sleep. So a lot of people say, well, I don't have any problem sleeping, or I sleep really well. Both obstructive and what we call central sleep apnea are increased in Parkinson's. So I think that fatigue is a significant thing. It's really important to do a sleep study, not only to look for obstructive sleep apnea, which is what we typically think of as somebody who's overweight and snores and wakes up short of breath. Central sleep apnea is where your brainstem just does not respond when you get those low oxygen levels and you don't get woken up. And what happens is you don't go into the normal stages of sleep, so you're tired. Other issues with Parkinson's and sleep are REM sleep behavior disorder. So if you yell, kick, scream, fight, act out your dreams, that's very highly associated with Parkinson's and can also contribute to poor sleep. Periodic limb movements where you kick your feet around. And the sleep study can evaluate for all of that. So I think that's really important. If all those things have been ruled out and been checked off, yes, I mean, fatigue may be just due to your Parkinson's. Patients really vary as far as medication. Some really have fatigue from medication. Some tend to get stimulated and don't sleep. So it depends on the medicine. Amantadine is one medication that we use more commonly in multiple sclerosis related fatigue, but in some patients with Parkinson's, sometimes it's a good adjunctive medication or even primary medication to help with fatigue in Parkinson's.
Well, that's a tricky, I know there are a lot of symptoms that are hard to treat, but that is one that is hard to, I know it's hard to assess and pinpoint. So Grace, hopefully you can work on that one.
We may have gone through all that laundry list, but if not, I just can go work through.
Yeah. So maybe a sleep study if you haven't already had one. That would be a good one to try to get on.
Can I add one more comment, Nina?
Sure.
Say about the sleep study, and I don't know how things are in New York with the sleep labs. Here they are open back up. We're in Texas, or we're outside of Austin, Texas. But an in-sleep lab is going to be important to have the study in the sleep lab rather than a home test if you can get it, because you really cannot evaluate for those limb movements. You can't evaluate for REM sleep behavior as well. They do put electrodes on your limbs to see if you're moving around. And so if you could get one in a sleep lab, that's going to be really important.
Okay, that's good to know. I didn't realize they were doing them at home. So
that's one, and a lot now insurances prefer it. It's less expensive, and so, and for some patients I think it's fine, but for Parkinson's in particular, I think the in lab study is great.
Okay. Let's see here. Trying to see if we got any other questions. Let's see. I think we got, there was one other question. So Heidi had another question about she has trouble with a frozen or slow arm when she's trying to exercise. She wanted to know if there was anything you could suggest to help stop the tremor when it won't let up. or it freezes mid.
So is it, it's always hard with these, with the questions, is it freezing or is it shaking? So is it?
Yeah, well, it is, there's something to stop the tremor. But I think she also at one point told me that it,
maybe doing both.
or freezes. Let's see. Heidi, I don't know if you can clarify that for us.
Some patients say that I don't know what kind of exercise that Heidi's doing, but sometimes if you have something in your hand, so if you're doing weights and pushing through something, or if you're walking or hiking, having poles like in both hands to kind of move them. If you're doing hand exercises, I know if you open and close your hand, that'll diminish the tremor. It doesn't take it away forever, but that does. I've had some patient recently, and I know in Austin they're doing music therapy where you walk with a metronome or hike. And I had a patient recently talk to me about that, how they had some therapy in Georgetown where they worked on that, and they have a metronome on their phone now that they're using to help kind of pace their cadence and help with that frozen part.
Yeah. Okay.
Really
all right.
options.
Well, that's great. We always try in our classes. I mean, we try to encourage people to, work through them, and we do use a lot of props in the classes.
Yeah.
But I know it doesn't work for everybody. But
right.
But that's good to know. Let's see here. One is the arm freezes or acts slowly, which is hard when working at the computer. And sometimes the tremors just won't stop and the arm gets tired.
So in some of those, on-demand meds for the tremor just not stopping. I mean, sometimes it just takes that compounding. Tremors in general, and anybody who has them has realized this, but they come out, if you already have a tendency to tremor, if you're cold or tired or excited or nervous, or have caffeine, that will escalate the tremor. And so it's just part of having tremors. As far as the computer, I don't know if her work has tried different options for that. That is a hard one, especially typing. I think mousing is the easier one to work around. Sometimes occupational therapy may be helpful, working with an occupational therapy who's experienced with tremors. With the tremor, I've had some patients use a weighted glove, almost like a weightlifting glove that's a little bit heavier. Sometimes that will dampen the tremor down.
Oh, that's interesting. Yeah. Okay. Well, hopefully that answered those questions, Heidi. So, okay. So I was curious. You and I were talking a little bit right before about the research, what research is happening right now with Parkinson's. And I thought what you had to say was really interesting. Maybe you could share that with the audience.
Yeah, so Nina and I were talking ahead of time about possible, upcoming new drugs that may come out in 2021. And I said, well, I don't really know what's coming in 2021 because a lot of trials were put on hold to either start or put on hold mid-trial because of the difficulty of getting participation. But 2 new drugs did come out that I guess were now been available since about mid-October. One is Ondemand, which is a COMT inhibitor. It's similar to a drug that's been out for many years called Comtan, and it basically prevents the breakdown of carbidopa levodopa. So you take it one time at night, and it prevents the breakdown of your levodopa that's in your system. So it's really indicated for off episodes, and I think it would be especially helpful in somebody who's having maybe off time at night when they get up to the bathroom, and then as well as delayed on in the morning and off time throughout the day. Most common side effect was dyskinesia. So for somebody who already has a lot of dyskinesia, may not be the best choice, or you may want to consider reducing the levodopa dose during the daytime. Your physician may want to do that. The other drug that came out is called Chemmobi, and it's a sublingual. It's the thin strip that you put under your tongue. Morphine is the generic name. This has been out for many years as an injection. Apogen is the injection for off periods. I think the side effect profile, we actually participated in the Chemmobi trial here in our office, and so I do have some experience with that just from a patient perspective. I think the side effect profile was pretty good. Nausea is probably the most common side effect.
Mm-hmm.
Part of the trial that we did here, patients did not take anti-nausea medication, and I was pleasantly surprised that most patients didn't have a lot of nausea. Some did, but most really didn't. The biggest complaint we got about it was the taste, that it didn't taste very good. And so some people would try to have candy or something afterwards to get rid of that taste. But it's also indicated for off episodes, and you can take it, I believe, up to 5 times a day, or you can take it in the morning if you wake up and you're off and you need to get started. A lot of patients, it will kick in about 10 minutes, and so you take that first, take your meds, take that first thing in the morning, and get kicked on. It works really, really well. There are other things that will be coming out, I think, in the future, but again, a lot of things just slowed down.
Yeah. Well, we'll hope that maybe with the vaccine, things will start picking up again, maybe later in 2021, if we're lucky.
Right.
That would be really nice. Let's see. Trying to see if we've got anything else. I don't think I see anything quite yet. Let's see. I was curious to know, what would you say are some of the most exciting changes you've seen with one of your patients or some of your patients who have begun an exercise regimen? And have you seen a reversal in symptomatology or delay in the progression? I know you touched on that a little bit, but is there anything that stands out, any specific?
Well, I mean, I think something that stands out in general, I think one of the hurdles getting over when you first get a diagnosis of Parkinson's, understandably so, is that you think, gosh, now I have Parkinson's, I'm at my peak. This is the best I'm ever going to be. And what I found with many patients over and over again is once you get started in physical therapy and you do regular exercising on their own, and maybe or maybe not medication, a year or two later, they're better. They're healthier, they're exercising, they feel better. Their symptoms have improved just with exercise. And I think that is motivating, and I think it's exciting, and it's, it really makes you feel that your hard work is paid off as well. So it's a big incentive to continue exercise. But I think trying to, tell people that on this end, and that's what I see, it's kind of a lot of disbelief in the beginning that in a couple of years, they may actually be doing better than they are now. They may actually feel better and be taking better care of themselves. And so I think, that's one thing I've seen repeatedly.
Yeah, when I interviewed Jimmy Choi last week, and he's really kind of a superhuman. I mean, he could do things that
people can't do.
We can't do. Yeah, if we tried in a million years, I wouldn't be able to do it. But he did say, one of the things he said is if he didn't have Parkinson's, he used to weigh 240 pounds. If he didn't have Parkinson's, he never would have ran all those marathons, and he never would have become an American Ninja Warrior. So he was highly motivated to keep going, and I guess felt the benefits.
I think when you're younger, there's that aspect. When you're older, the other thing I see is I do have patients diagnosed in their 70s, 80s, even 90s, and they say, well, I didn't grow up exercising. I've never exercised. Like, this is just, especially if it's a woman, they would say, we didn't do that. So this is not something I'm used to doing or comfortable. But they do, and they do great, and they improve. And I think a lot of people they're proud of themselves, as they should be, because they improve upon where they were, and that they get those comments from their friends and family members. And so it really doesn't matter what age. There's not a limit to age that, you've hit a certain point and now you can't get better or improve, or it's just, I don't agree with that at all.
Yeah. I mean, I agree. I think it's really remarkable. And of course, when we used to have the live or in-person classes, just to see, an entire room filled with, many people that were probably in their 70s and 80s, 50 or 60 people doing these super highly complex exercises is just, and a lot of people, like you said, had never exercised. I mean, maybe they took a walk or something like that, and then the changes are just remarkable. And people ask us that all the time, like, are you sure, I could do this? I haven't exercised. And
Right.
it's great to see, and great to see that people can benefit like that. Let's see here. Somebody did ask if you have any suggestions for managing cramping and dystonia.
That's a good question. So some patients with Parkinson's and dystonia, they do respond to any dopamine medication may help. If it's not helping, there are other options. So some patients, more of a muscle relaxer like baclofen may be helpful. Sometimes something that works on a different neurotransmitter called acetylcholine. There's a medicine Cogentin that I found helpful for some people with the cramping. Usually I try to go through several medicine options. If that doesn't work, Botox is actually a really effective treatment for some patients. And I find that the younger onset patients tend to have a more pronounced dystonia and more dystonia in general. So Botox is always an option. I mean, it is FDA approved for different forms of dystonia, but most insurances, even if it's a leg or an arm dystonia, will cover it.
Oh, that's great. Yeah. So when we talk about young onset, I just wanted to bring that up because you have been instrumental in helping encouraging me and encouraging the organization to start a young onset group, which we have, and we appreciate you referring some of your patients to us. And what do you see as some of the specific challenges for that group? And could you just define what young onset means to you or in the medical field?
Yeah, so young onset traditionally really is somebody younger than the age of 50. Typical age of onset 60 to 65. So then you do have this group that's kind of between group in the middle that's 50 to 60. So a lot of people may lump them more into a young onset if it's less than 60, but traditionally it's less than 50. I think there's a lot of challenges. I think one, Parkinson's as a society we think of as a older person diagnosis. And so when you're in your 20s or 30s or 40s and you get diagnosed, it's thought that it's impossible to have this diagnosis. And I've definitely seen that in my practice where a patient has gone to different physicians and said, oh, you can't have diagnosed, you can't have Parkinson's because you're only 38. So you don't have that, but unfortunately, the patient does. I think the challenges are people in their middle ages of life are involved in child rearing, jobs, and that's a whole other, trying to keep people working and keeping them very active with kids, I think it's hard. I think the perception is worse than actually trying to do it in many ways, because I think, again, it's that diagnosis time and then realizing that a year or two or three later that they're doing better and they're actually doing quite well. But it's always, it's always in the back of everyone's mind, and how much longer is this going to work and what's my next step. I think the positive, though, is that now we do have not only more medication treatments. I mean, this year, just to get a couple new drugs, it's great. I mean, we went years with no drugs approved, and then there's so many things in the pipeline. There are surgical treatments, and the surgical treatments, DBS has been approved now for close to 20 years, but it's improving. I mean, the software capabilities and some of the things that are going to come out of that are going to be better and better. So there's a lot coming, and a lot that is really, rather than symptom management or treatment, there are many drugs in development that are looking at neuroprotection, slowing progression, stopping progression, and those are going to be the real game changers. And I do think, and I tell every patient that I have, especially the younger ones, that when the next 5 to 10 years for Parkinson's, I think it's going to be a really exciting time because there's so much on the horizon, and we don't know exactly what's going to pan out and be the best yet, but there are a lot of front runners. And I think that the way we treat patients in the future, rather than putting them on symptomatic treatment, is we're going to get everybody on something to stop their slow progression and then treat symptoms as well, like we've been doing. But the ability to keep somebody where they are when they're first diagnosed or progress at a much slower rate is going to be key.
Yeah. Yeah, it does sound like there is a lot of exciting, possibilities in the future, and that life doesn't have to end with a diagnosis. It's really important. It looks like we don't have too much time left here, but we just got one more question. I think this comes up periodically, but Karen, who's in Canada, she would like to know if you recommend the use of THC for some tremors and freezing specifically.
Yeah, that's a good question. So there are a lot of options. In Texas, THC or medical marijuana was approved for neurodegenerative conditions last September. I should say September of 2019. So a little over a year ago. So I do think that it can be helpful for certain things in Parkinson's. I think tremor, it could be helpful. I think stiffness, it could be helpful. Sleep may be helpful. Anxiety may be helpful. There's not an established dose of exactly how much to put somebody on. So because we have that availability, what I do with patients here is put them on kind of a standard titration schedule and start them off just at bedtime on a low dose, and then gradually work up to a twice a day dosing schedule, and see how they do. Some patients love it, and it's been a game changer. Like any other medicine out there, it is not for everybody. Some people have side effects, or they don't, they just don't feel that it's been helpful, but I definitely think it's worth trying. So
yeah,
I think usually I have patients make sure that they've tried some form of CBD before we go straight into medical marijuana, just in case if they have a side effect on CBD oil or tincture or drops, then then obviously you wouldn't want to do medical marijuana because it's CBD plus THC.
Right. Okay. Well, that's always a hot topic that people are interested in, and I know seen some positive effects. So let's see. I know you've got to wrap up soon because you have a patient coming in to your clinic, but I just wanted to see if you had any tips for our audience today, getting through the pandemic, the isolation. What are the things that you would recommend for going forward for someone with Parkinson's? And
yeah, so I mean, it's the isolation is very real. I mean, especially for those people who, I mean, we are all isolated. All of our lives are different. Some people's more than others, certainly. I think it's really easy to get off track and get off schedule. So I think trying to maintain a schedule, a daily schedule, is really important, because if you don't and just say, I'm just going to sit inside all day, there's a lot of elevated levels of depression, anxiety, worry. So trying to not watch too much TV, because there's a lot of stressful things out there. I limit it myself. I try not to watch the news that much.
yeah,
and focus on things that you can do and things that you enjoy doing, and trying to put exercise in your schedule every day, but also making time for friends and family, even if it's through. I know it's not the same as seeing people. It's not. But we're fortunate in that we at least can do that. And for my practice and my patients, telemedicine has been a saving grace, because many of my patients I just wouldn't have seen for a year. And it's at least we can do it. It's not great, and
yes,
it doesn't always work, but I think trying to maintain your social relationships and get on some sort of schedule, because none of us knows exactly what's going to happen. But if you can try to take each day and do something meaningful, I think that's
yes. Well, I think that's such good advice, and we just hope, for Parkinson's, hopes that we can be part of people's schedule. We do now. I think probably most people on here know we have classes 7 days a week, and we like to get people on so they can chat, so we can talk to each other. And we do get to know a lot of people, so it's been fantastic getting to know all these people. And I just want to encourage those who haven't been on the chat. We have a whole description as to instructions in the latest email, how to get on chat. We put in some instructions how to get on Zoom. So maybe you Zoom with your family. In addition, we have one Zoom rhythm and moves class each week, and Zoom phone calls just to engage people. But I agree with you. I mean, having a schedule, having something that you look forward to is great. And if people can get outside, I know it's cold, but if it's possible, getting some fresh air is always helpful. But I just want to thank you for coming on with us today. This was really great. And it looks like we're getting some positive feedback. And thanks to everybody who was watching today and asking all those great questions. And Dr. Peckham, you're an excellent resource, and we're grateful to have you today.
Thanks for having me.
All right. I hope you have a great holiday and Happy New Year. And we'll look forward to lots of health in the coming years.
Sounds great. Thank you.
Okay.
Okay. Take care. Bye-bye.
All right. Bye-bye. Thank you.
You're welcome.